been known and realized that people with rheumatic diseases, whether it's rheumatoid arthritis, psoriatic arthritis, ankylosing spondylitis, all of them have high risk of developing cardiovascular events. And the other area that's been investigated is, one of the issues is that many of these risk factors for developing cardiovascular outcomes, like having high cholesterol levels, high blood pressure, are not being managed very well by us rheumatologists, because we focus more on treating the joints, and we have limited amount of time and we can't deal with everything. So we don't do good job in addressing these issues. And as a consequence, these patients that are at high risk of developing heart attacks and stroke are not being treated as needed for these risk factors. So our group is interested in finding ways to improve the management of these risk factors in rheumatic patients. So we came up with a new model of care. So it's a collaborative clinic and collaborative program. We work very closely with our colleagues from cardiology. Fortunately, our cardiologists are very interested in this interaction between inflammation and cardiovascular outcomes. So our model of care is a combined clinic of rheumatology and cardiology. We refer our patients for primary prevention of these cardiovascular outcomes to the clinic, and so the setting is, we are in an academic center, so there is also a research component to it, and we evaluate these patients using different modalities. We're trying to come up with a model that will identify patients that are at high risk of developing these outcomes, and also to treat these risk factors that I mentioned before, so manage better their blood pressure and cholesterol, and encourage them to be more physically active and stop smoking and lose weight, all of these issues that are important, but again, may not be managed as well in rheumatology setting. So this is one model that we propose, and I guess one of the challenges is to try to think about other ways to address this problem in non-academic centers where people may not have these resources, and think about other ways to improve the management of these risk factors in rheumatic patients. We established the clinic a year ago. So far we've seen about 150 patients. About half of them have rheumatoid arthritis, half with spondyloarthritis, so both psoriatic arthritis and ankylosing spondylitis. We found that there were significant proportions of patients with untreated high blood pressure, high cholesterol. So there is a need for treatment, for better treatment. So that's one lesson that we learned. We have made significant change. Also, as a consequence of being evaluated in the clinic, 50% of the patients needed some sort of change in their treatment. So either initiation of lipid lowering agents or aspirin. And there were even a few patients where needed interventions, like we had one patient that had angiography and stent implanted because she complained of having shortness of breath that is not typical cardiac manifestation, but after being investigated and assessed in the clinic, she was found to have significant heart issues. So I think overall, summarizing the first year, I think we do make a change. We hope to collect, so as part of the assessment in the clinic, we collect information in a standardized manner. So we collect information about diet and about physical activity, and we do different types of imaging to assess the function of the heart and the blood vessels. And we want to come up with models that will help to better stratify patients according to their risk of future development of heart events. So this requires some time to collect enough a large number of patients and to follow them up longitudinally to have enough events to be able to analyze. So I hope that in the next couple of years we'll be able to come up with new ways to identify these high-risk individuals, and then we can hopefully prevent these life-threatening events.